Okay, got it. Hello everyone, this is Rajesh, Lead SPIs working in Poison Information Center in Nepal. Um, so these are the outline that I'll be discussing today Uh, so on December 22 at 6 o'clock, 6 p.m., the patient ingested the rat poison and is brought to hospital. And at 6:54 p.m., 1854, we received the call from Chaudhar Hospital about suspected rat poison ingested for suicidal purpose, and no photos of poison was available at the time. The patient presented with nausea, vomiting, pain, abdomen, jitteriness, vitals were stable, conscious, alert, with GCS of 15. Uh, in 1856, the differential of superwarfarin or zinc phosphide as a common rat poison was done and requested baseline lab investigation to the treating physician. On 7:20 p.m., the treating doctor, they sent us the photo of the poison the patient ingested, and it was zinc phosphide. So the brand is Ratil compound zinc phosphide in powder form with 80% weight by weight composition of zinc phosphide. 5 to 10 gram was ingested, and the time the patient ingested the poison was 5 to 5:30 p.m. And the intention was suicidal because of quarrel with husband. Um, on the same day, on 1932, we consulted the international team and recommended gastric lavage or angiotuve suction is discussed. And after 3 minutes, the gastric lavage with activated charcoal was started with all ABCD management and lab investigation were sent. ECG was normal. Lab investigation also came to be normal. No ABG or ICU services available at the hospital. So we discussed about need of ICU and refer the patient to the higher center. On day one, on December 23, at 10 o'clock, we called the patient and we got info. We already took the patient phone number, so I followed up with the patient to know where the patient actually went for ICU. So we called at 10 a.m. and we got info about the hospital. I called directly the hospital number and talked with the ICU sister, and patient had acidosis and hypotension, but I couldn't get much more information from the sister because like she couldn't share all the information. And at 6 p.m., the patient I followed up again, and the patient was in ICU, was feeling better, and the plan was to transfer the patient out to ward tomorrow. On December 24th, day 2 at 3 p.m., I followed up the patient, and the patient was already transferred to the medical ward as the patient was doing better and the vitals were within normal limits. On day 3, again 3 p.m., I followed up the patient. She was doing better, vital stable. Currently, she is in the same medical ward. Observation on day 4, 3 p.m., followed up again. Looks like the patient was recovered and discharged home because I called the ward and they said there is no patient name dot dot with zinc phosphide poisoning. So yeah, and I assume she was recovered and discharged home. So this is the timeline of the patient that we got about zinc phosphide. She recovered finally, which is very good, and we were able to follow her till from the initial hospital to finally recovered and getting back to home, back to normal life. So to compare, today since we'll be discussing about the toxidrome of phosphine gas, so we will be discussing these things. So we have two chemicals commonly found in Nepal that produces toxicity by phosphine. So one is zinc phosphide, comes as ratil or ratnil. Another is aluminum phosphide, comes as a tablet. Now it's also in the powder form. Aluminum phosphide comes as cellphos or quickphos in Nepal. Mechanism of action is or mechanism of toxicity is same. They both releases phosphine gas with water or hydrochloric acid in GI tract. The basic uses of zinc phosphide is rodenticide and aluminum phosphide to be rodenticide, and also the bedbug fumigation that I knew the day before yesterday because the one of the hospital from Kathmandu they called me with the patient ingesting the bedbug or udus fumigation poison, and later we found that it was aluminum phosphide. The toxic dose of the zinc phosphide it's not clearly mentioned, but I found that 4 to 5 gram of the zinc phosphide is toxic, and 1 gram of or 1 tablet or 3 gram of aluminum phosphide is toxic or lethal. The action of zinc phosphide is very slow, so the symptoms we get could be mild or like very less as compared to aluminum, because it produces phosphine super fast, and the symptoms appear faster than zinc phosphide. So the phosphine is produced in plastic, and so in industries, it's very interesting that the phosphine gas is produced in plastic and semiconductor industries as well, and they have set a limit of the phosphine, which is if it's more than 50 parts per million, it's very dangerous to life, and if it's 400 to 600, so it's mainly for industrial purposes, it's lethal. Phosphine, it is the mitochondrial toxin. It inhibits the oxidative phosphorylation, and also it's a nucleophile, so it's a strong reducing agent, and it helps in the formation of reactive oxygen species and cellular peroxidase, which does the lipid peroxidation and eventually leads to cell death. So the another mechanism that the phosphine gas does is it does the reduction of glutathione concentration in tissues. So the people measure the glutathione concentration in tissues, and they suggest that the phosphine gas also reduces the glutathione, and it causes accumulation of free radicals and others. So these are the factors that cause toxicity. Also, in the patient with aluminum phosphide, there are indicators of oxidative stress, like there is reduced glutathione and others. So, the people found that the peak levels within 48 hours of exposure, like there is reduced glutathione within 48 hours of exposure, and the glutathione level in blood reaches normal by day 5. So signs and symptoms. The person who is ingesting zinc or aluminum phosphide is releases phosphine gas, as we talked already. So the symptoms are very rapid, and one case series of 92 patients, it reported that 55% of the death was within 12 hours and others was within 24 hours. So this is the statistics that we got in our poison information center. Here we had 11% of the total patient we received had zinc phosphide, and 5.1 had aluminum phosphide. So total of 17% of the patient that we saw within last 6 months, we had zinc or aluminum phosphide. So the early symptoms, the people usually present to the hospital with GI symptoms like nausea, vomiting, epigastric gastrointestinal pain, diarrhea, and the very a dangerous thing that we early symptom that it's very dangerous to life is like hypotensive shock, cardiac failure. These are the signs of severe poisoning, and the complication includes refractory hypotension that we all the clinicians are afraid of. Another big thing about the phosphine is lactic acidosis. Since it is the mitochondrial toxin, it blocks the oxidative phosphorylation. So all the glucose that goes into lactic acid pathway and causes lactic acidosis and metabolic acidosis. The other symptoms include like pulmonary edema, respiratory failure, anoxia. In neurological, there is headache, dizziness, drowsiness, and the people generally remain conscious till cerebral anoxia. Many of the patients, they remain conscious, and later they deteriorate rapidly because of the refractory hypotension, acidosis, and neurological features like drowsiness, delirium, and coma. So early complications, it includes like refractory hypotension, metabolic acidosis, hypokalemia secondary to vomiting or GI losses, and hypoglycemia. Sometimes hyperglycemia has also been noted, and another is methemoglobinemia, which is very rare complication of phosphine. So late complication includes like there was a study on follow-up among survivors, and then they had esophageal stricture or tracheoesophageal fistula. So the patient who has been discharged from the hospital, they need to be counseled about follow-up in GI for endoscopy or like further evaluation of these things. So what are the poor prognostic factors for the aluminum or zinc phosphide? One is acidosis, pH less than 7.25, mental status with GCS less than 13, hypotension with systolic blood pressure less than 87 mmHg. The others that correlate with the poor prognostic factor are lactate. Lactate more than 6.9 millimole per liter has 100% sensitivity and prediction of mortality. And another is hyperglycemia at admission. So here is, I would like to present one of the patient that we saw in PIC on December 25. He had ingested aluminum phosphide. The pH, the initial, we had the lab investigation within 1 hour of the presentation. The pH at the time of presentation was 7.23. So it correlates with the poor prognostic factors here, which is very less than the factors shown there. GCS was 10 at the time of presentation. Systolic blood pressure was 80. So now we can clearly predict the outcome of the patient. And also lactate was 8.4, which is very more very large. So we can clearly predict the outcome. Outcome was dead within 6 hours of ingestion. So these are the poor prognostic factors and very important in predicting the mortality related with zinc and aluminum phosphide. So the basic management. So I'll moving on to management. First thing is ABCD approach. So we need to maintain the airway, adequate ventilation, give oxygen, IV line, monitor vitals, cardiac rhythm, glucose, pupil size. And next thing on poisoning is decontamination. So we usually do gastric lavage or NG tube suction, depending on the available resources. So gastric lavage with potassium permanganate 1:10,000 is recommended, which oxidizes the formed phosphine to non-toxic phosphate. Followed by 100 gram or 1 gram per kg of activated charcoal to reduce the absorption, and it should be done within 1 hour of ingestion. And we can also add sodium bicarbonate in the gastric lavage fluid, as it neutralizes the gastric hydrochloric acid, and also it reduces the formation of PS3, because the aluminum or zinc phosphide, it reacts with gastric HCl and forms PHC. So sodium bicarbonate is also recommended to add to be added in the gastric lavage. So what are the diagnostic points? So the first thing in poisoning is the patient is always cannot speak, or like, so we need to get other things around, like sachet or pellets around the site of incident, patient history. In aluminum or zinc phosphide, we could smell the garlic on the breath due to impurities. And next thing is silver nitrate impregnated paper test, which turns the paper into black. So this also confirms that there is phosphine forming in the abdomen, and we can clearly predict even if we don't know. And there is no any specific antidote for this poisoning. The investigation and monitoring, what we need to do, we need to get the baseline investigations, like complete blood count and etc., electrolyte, calcium, magnesium. Monitor them regularly in symptomatic or with person with abnormal finding. Do chest x-ray, cardiac rhythm. In ECG, there are like series of findings that we might see. So initial 3 to 6 hours, we can find sinus tachycardia. Later, we will find ST changes, conduction disturbances, and later arrhythmias could occur. So we need to be aware of these things and need to have continuous cardiac monitoring. So the supportive therapy is the mainstay of the treatment, since we don't have any specific antidote. So we need to do the management based on the finding or based on the abnormalities. So to go into specific management, for hypotension, it's due to phosphine-induced reduced cardiac output. So because of which we have hypotension in the patient, and it's also one of the poor prognostic factors. So we need to correct the hypotension earlier. We need to give aggressive fluids, and vasopressor like norepinephrine and inotrope support might be necessary. And if necessary, we might also need to give ECMO if we couldn't manage it with above treatment methods. And also invasive hemodynamic monitoring might be needed, since we are pretty afraid of the refractory hypotension, and since it's one of the poor prognostic factor, we need to monitor the BP and cardiac thing, even if it's necessary to have invasive monitoring. Other are metabolic acidosis. Lactic acidosis is due to impaired oxidative phosphorylation. So we have lactic acidosis in this patient, as we talked already, and it's also one of the poor prognostic factor. So we need to give sodium bicarbonate. We need to correct potassium before giving sodium bicarbonate. Here are the doses for adult and the children. Next thing is hypokalemia that we need to be aware of, secondary to which is mainly due to vomiting and diarrhea. We need to correct with potassium chloride. In severe, we might need to give IV fluids. Otherwise, oral potassium chloride or dietary intake is enough. Next thing is hypoglycemia. It is due to impure gluconeogenesis or glycogenolysis in due to phosphine-induced toxicity. IV glucose or dextrose is enough. Next is methemoglobinemia, which is a very rare complication, and we need to think about it. If the patient develops sinuses and are not responding to oxygen therapy, so we need to keep this in mind. And we might, and the treatment is high flow oxygen, and sometimes antidote therapy with IV methylene blue could be given. And before discharging from the hospital, we need to do the barium swallow or endoscopy to detect the esophageal complication like tracheoesophageal fistulas. And here comes the discussion. So these are the things that these are the new things coming up, and there has been a lot of studies going on. So I'd like to discuss these things and with the aluminum zinc phosphide. So one thing is magnesium sulfate in metallic aluminum zinc phosphide poisoning. I couldn't find this information in others, but when I went to teaching hospital and when I see the cardex, the patient was given magnesium sulfate, and I asked one of the resident, and they told me that magnesium sulfate, it's good. It's being used in aluminum or zinc phosphide. So I went through the papers. Looks like it acts as a cell membrane stabilization factor, and since one of the fatal complication was arrhythmia in phosphine, there has been theories that giving supplementing magnesium sulfate could reduce the incidence of fatal arrhythmia, and but still exact mechanism is still being unclear. It also has antioxidant effect, so it combats it reduces the free radical. So the doses that there are, people have devices the doses for the aluminum or zinc phosphate poisoning. But there was a recent study which shows that mortality was not significantly different in patients who were not treated with magnesium therapy. So to conclude, at present, we don't have enough evidence for it, and the routine use of IV magnesium sulfate therapy is questionable because there has been cases where there was hypermagnesemia seen with aluminum or zinc phosphide poisoning. So it's very questionable, but people are still using it. So next thing is N-acetylcysteine in cysteine has also been used. Same thing when I went to teaching hospital, I saw the patient were given NAC as well. So I went through the papers and found that since one of the mechanism of toxicity with phosphine was the oxidative stress because of the free radical injuries with reactive oxygen species, different things like different antioxidant drugs were studied and has been used in the treatment of aluminum phosphide, like glutathione, vitamin C, beta carotene. But only thing that was promising was NAC. So people are using it. It stimulates the glutathione synthesis and counteracts the damaging effect of free radicals. So it has been using. People are using it, and in the experimental study, NAC reduced the myocardial oxidative injury, and it has improved the patient. So it has been using. And to conclude with NAC, NAC might be promising, but there are not enough human trials. So I think NAC could be the next best thing coming up for aluminum or zinc phosphide, and we need more human trials to devise the adequate evidence. Next thing coming up for the aluminum or zinc phosphide poisoning is hyperinsulinemia, euglycemia therapy or height therapy. So people are giving insulin and glucose for the treatment of aluminum or zinc phosphide. since it can restore the hemodynamic state to normal, it also increases cardiac contractility and improves the tissue perfusion. So people are using hyperinsulinemia, euglycemia therapy, um, which with the loading dose. So people are also using in this form with high dose insulin and glucose, maintain the glucose within 100 to 250 mg per dl, monitor glucose regularly 15 to 30 minutes, and then since after we got the good glycemic control, we can do it every hourly or every 4 hourly. Record, monitor electrolytes, supplement, um, and we need to target the hemodynamic stability for this therapy, which I've mentioned here. This is very interesting that new things are coming up for the management of aluminum and zinc phosphide. Next thing coming up is intravenous lipid emulsion, or ILE. So it was introduced in 1960, and later in 2010 it has been started to be used for organophosphate and other toxins. So ILE, it acts as a lipid sink, and since phosphine is high lipid soluble toxin, so the ILE therapy, since it's a lipid sink, it will neutralize the phosphine and reduces the plasma level of toxin, because of which the symptom related to phosphine will be decreased. So these are the loading dose followed by infusion of this, and when to stop, maximum duration. So we need to stop ILE after the resolution of toxicity are okay. Next thing is water versus well decontamination in metallic phosphide poisoning. Since the aluminum or zinc phosphide, it reacts with water of the gastric lavage or fluids, and it may increase the phosphine gas production. So there has been ongoing studies about how to do the gastric lavage, whether we use water or we can use other things. So recently, the oil-based solutions are also being tried for aluminum and zinc phosphide poisoning, like liquid paraffin, coconut oil. These are being used, but we don't have enough evidence yet for the use of oil-based solution instead of NS. So these are kind of questionable, but we could try these things as well. So to summarize the things that we discussed, first of all, there will be suspected or accidental inhalation with aluminum or zinc phosphide. Then they present to hospital. We do basic ABCD management, maintain airway, breathing, circulation. Then we get to the emergency. We have history examination, and when we go through the signs, symptoms, complications, with multiple systems. We monitor vitals, and so we suspect the aluminum phosphide poisoning, and we do the diagnostic test with silver nitrate test, which turns the paper black. When we consult the regional poison center in Nepal, it's 0145020011. We do gut decontamination with KMNFO, sodium bicarbonate, and coconut oil. Later, we do basic investigation for the organ insult, and we watch for signs, symptoms, and give management accordingly. So the first thing that we need to aware of is arrhythmia. We do the cardiac monitoring, do regular ECGs, continuous cardiac monitoring. Next thing is shock, that we are very afraid of. Refractory hypotension, we give aggressive fluids. Inotrope support, norepinephrine. And next thing is respiratory, ARDS, so we give oxygen, ventilatory support. Next thing is metabolic acidosis, we give sodium bicarbonate, and we do hemodialysis if necessary. Other is we maintain the electrolyte, blood sugar level, magnesium sulfate, steroids, vitamin C, NAC. Multiple things could be tried as long as it's beneficial to the patient. So this is the summary. And the challenges that we face is, like, sometimes tox base alone is not enough in clinical management. So having up-to-date or like other resources would be an extra benefit. So we don't have much journal access. So having journal access would be nice. The next thing is regular case discussion and also the well-established team of experts, because sometimes we get confused and we couldn't get answers within minutes or like within within short time. So having these things in within our fingertip would be nice, and having on-call experts or consultant would be also nice. So these are the references that I took, and here comes to the end of my presentation. And I look forward to have any. Do you have any questions? Any discussion point? Thank you.
Rajesh, good job. Yeah, I think that was a really good summary of a really important pesticide poisoning in Nepal and around the world. A few questions about this. So, one, are the on your research, did you find that most of the sort of rodenticide that are used now, are they mostly superwarfanes or are they mostly these?
There are superwarfarin as well, like bromodiolone, but
How common are superwarfanes in Nepal?
it's common. Like we've seen, we usually have the bromodiolone, which comes as rat something as a brand
Okay.
name. It's very common. It's a superwarfarin, but zinc phosphide is more common than superwarfarin because it's number one now that we get called in PIC. So it's very common. Zinc
Okay.
phosphide.
And then is the banning in our country, is one of these things banned or no?
Uh, the tablet form of aluminum phosphide has been banned,
Uh-huh.
as far as I know. Now we have the powder form of aluminum phosphide, and the patient that I had last time, like few days back, he ingested the tablet form of aluminum phosphide that they bought for bedbug fumigation, like years back. So it was as a stock in their room. He quarreled with his family and just ate the tablet. So I think the tablet form was of the aluminum phosphide. It has already been banned in Nepal, but we still get powder form.
Okay, lovely. No, good job. Good job. You did a really thorough research, so that was really good. You know, I would work on trying to trim this presentation a little bit, make it a little bit more, because this would be a really nice presentation for you to give at some sort of case presentations in conferences. So it would be nice for you to just work on this presentation to make it a little bit better. But I think this is really good. Thank you. Does anyone else have any questions?
Okay, well done, Rajesh. This was a nice presentation. So on my part, I would be asking few questions. So I'm not very sure whether I missed or not, but when you were presenting the case, whether she dissolved it in water or was it ingested directly?
Oh,
I might have missed it.
no, the zinc phosphide one, she ingested it directly. The zinc phosphide that I presented, it
Okay.
was in powder form. The thing was that she quarreled with the husband and she took it in her mouth.
Mhm.
The husband saw like immediately and he get the powder out of the mouth.
Uh,
As we discussed, the toxic dose of zinc phosphide was between 4 to 5,
Gram, yeah.
and we assume she consumed around 4 to 5 grams of the zinc phosphide. But I think the husband took the powder out of the mouth, and because of which she could survive.
Okay, I'd like to
But with the
add.
aluminum phosphide,
Mhm.
the that I presented here, he
Yeah,
ingested tablet. Yeah, he ingested tablet. And what I found is that between tablet and powder form, people find it very hard to have the powder form because it's very hard to drink without water for the powder form. So I think the banning the tablet form is a very good decision.
Okay, that's very good. The other thing is, I'm not very sure whether you've researched why does phosphine gas causes high refractory hypertension. Is there any evidences like the mechanism that you're aware of? Do you find any resources towards it?
Yeah, I found
Is it
that the phosphine gas, it reduces the cardiac output, because of which there is hypertension. This is the
no?
only
I
thing that
mean,
I
why
found.
does no? I mean, is it due to myocardial my problem with myocarditis, or is there any other mechanism? Because as you have already explained very well, it can has cardiac complications such as arrhythmia. So,
Mm.
is that the mechanism or anything? So this anything more that you will further add in?
Um, As far as I know, I think it should be through the oxidative phosphorylation, since all of the tissues and cells they need oxygen, and since the phosphonate inhibits the oxidative phosphorylation, because of which there is like cellular hypoxia or anoxia, and I think the basic point where all these systems involved is through the cellular hypoxia and anoxia. But I'm not aware. Like I don't have full answers to it.
Let's work into it. The other thing that I'd want you, my personal opinion, I think the team might also add in. I don't want you to use the word like teaching hospital when I went to teaching hospital. It's fine that you go to teaching hospital, but for future references, it's better that the hospitals have, I've studied, or I know some hospitals use is maybe a little better in terms, because if this is recorded, this will be ongoing to mass public. And if someone expires due to magnesium sulfate, for example, take for example, despite using MagSolve, someone expires, so your evidence does not support in favor of magnesium sulfate. It only favors if, for example, if there is cardiac complication. My question was, in the end, in the summary, you mentioned that in cardiac complication, we can use MagSolve. This is out of the box, but was every cases in teaching hospital used with MagSolve, or only those which had ECG changes? Did you try to wander on it? Did you work out to see for it?
I don't think I have enough answers to it.
Yeah,
Yeah, I agree.
because
I should have named
yeah,
the name of the hospital, which I realize now. But I don't think I've gone that far. Like,
okay. No,
but
this
because
is well
yeah,
presentation. I really appreciate it. So just on my part, I found these things like when we're presenting, like Dr. Ramo already stated, it is already a great presentation. It would have added more flavor if it was seamless. And I really look forward to having this kind of sessions. So well done. So we'll hope to have these answers in our other discussions. So thank you so much. It was a wonderful presentation.
Yeah, guys, I have to leave in 3 minutes, so I'm just gonna say a few things, and then you guys can continue with the meeting. I think for this type of things, Rajesh, so this should, when you do this, we need to make sure two things. One, we invite our international people on the international group.
yeah.
And two, everyone from TU needs to be in this. TU is leading this poison center. They cannot not come to this type of meetings. And especially people who are in Nepal, Praveen and Dr. Akriti and people like that, like from the department, like we should coordinate with their schedule. And if it, I don't know if they agreed to come to today's meeting or not. Had they already agreed? Do you know if they had said yes to this meeting today?
यस त अलि भन्नुभएको जस्तो लाग्छ मलाई चाहिँ अस्ति कुरा गर्दाखेरि अब
Yeah, you
टाइम
see,
पनि
so it's not acceptable, right? Like we can't have a teaching meeting with the department that's running this poison center with something like this and them not showing up. So they really need to be in this type of meeting. So please make sure that's coordinated next time, because this is a learning part. Like I'm really a weekly meeting on that. You're learning wala halko macha, they should all be represented. And then we should try to also have our expert toxicologist, because they can, the kind of feedback they can give, we cannot give. So
there's so many conditions, so I think we need to have international team and like experts to be in the presentation and
yeah, were they invited?
No, we didn't. Like we're not sure about it. Maybe we could do it later or in the next meetings.
Yeah, invite them, right? Like the same group that you're asking questions, and you can say, hey guys, we're doing a presentation at this date. It would be great if you join. And they seem very excited. They are all very interested in, it seems like, joining and contributing. So I think that would be good. But either way, that being said, I have to hop off to another meeting. I'll catch up. Is there anything on the weekly meeting agenda that you need my answer in, or no?
Less toxic is because the reason why zinc phosphide is less hazardous. The people who are taking zinc phosphide has less mortality as compared to. The reason is zinc phosphide is available in crystalline form. Crystalline form, and they have to take water to ingest it. So they can't take it like directly to the mouth. And palatable पनि हुँदैन अनि गाह्रो हुन्छ. That's why they use water. When it gets dissolved in water, it reduces the phosphine gas, and after all, induces the cytochrome oxidase C, and then the subsequent process, all process will go on. So this is the reason why zinc phosphide, aluminum phosphide, aluminum phosphide most other days. Even one tablet can lead to 90% mortality. 2 tablets is 100% mortality. It again depends upon the body weight, because if there's more fat, 1 gram can lead to less mortality. If there's lean body mass, one tablet will lead to the mortality of the patient. So this is the basic. I'm sorry I missed the presentation. I just want to make clear about this. अनि अर्को चाहिँ के छ भन्दाखेरि चाहिँ अब I don't know अहिले न्यू डेभलपमेन्ट छ अहिले एल्युमिनियम ट्रिटमेन्टमा यदि कसैले सोध्यो भनेदेखि चाहिँ so Rajesh, did you mention about the NAC in the treatment of aluminum phosphide?
हजुर सर
NAC
डिस्कस गरे सर हजुर
okay,
म
that's fine.
पोइन्ट हुन राखेको थिएँ अब त्यो
I'm so sorry म त थाहा नै भन्नु कस्तो म त I'm so sorry I missed the presentation. My sincere apologies. So I should have joined this. Next step it I'll join.
All right, guys, continue. I have to go. Thank you, Dr. Rakesh, for your answers.
Okay.
Bye-bye.
Okay. That's a knock is sir. अर्को चाहिँ मैले magnesium sulfate पनि भेटे.
Magnesium sulfate. Yes, max sulfate is used. The cardiac arrhythmiasहरूको लागि cardiac उसको लागि चाहिँ max sulfate is used. Because magnesium sulfate is widely used in treatment of hypertension in pregnancy, and then the treatment of agar phosphate poisoning पनि it is recently developed. And especially it is the magical drug. Magnesium sulfate, max sulfate is magical drug. It is used in most of the poisoning cases. क्या oily जस्तो छ. तर अहिले recent advances मा चाहिँ NAC. The reason why NAC is used in the treatment of aluminum phosphide is it is believed that aluminum phosphide would lead in the reduction in the glutathione. Glutathione reduction गराउँछ क्या. Liver enzyme चाहिँ glutathione.
मेन्सन गराएछु भन्ने त होला नि.
ठिक छ I'm sorry. अब त्यो भयो अनि अझ त्यही अब डाक्टर एकजेल दिनुभएको कमेन्टहरू पनि मैले सुने. एकदम राम्रो फिडब्याक दिनुभएको छ. राम्रो कुराहरूले सुने. Good presentation overall. Actually, if you don't mind, अब अरूलाई मिटिङ सिधै लास्टमा पनि हेरौँ actually. Weekly meeting गर्नु सिधै.
The weekly moderate